everybody, and thank you for joining me in this short video presentation. Let's look together at the two ECGs that I put on Monday on the website and see the localization of the PVC and the diagnosis of the patient with aborted sudden cardiac death. The PVC in this ECG has a left bundle branch block pattern. It means it should be right ventricular. In limb leads, we have an inferior axis. It means it should be somewhere in the right ventricular outflow tract. Then we look closer and we see that there is a notching in inferior wall, and also the 1 is positive. It means the PVC origin should be somewhere in free wall of the RVOT, most probably posterior part of the free wall. But when we look closer at AVL, we see that the AVL is positive, and it means that the PVC originates from the lower part of the free wall of RVOT. So we started to map, and finally we find that the earliest point, which was minus 40 milliseconds earlier than the beginning of the QRS complex, was actually in the pulmonary artery with a pace map score of more than 98%. This is an interesting ECG in patients with PVCs originating from the pulmonary artery with a positive AVL. Actually, at that location, we don't expect a positive AVL in the ECG, but it looks like that there is some special conduction from pulmonary artery to the free wall of the RVOT, putting together left bundle branch block pattern, late transition, means and right ventricular PVC, inferior axis shows outflow tract, notching depicts the origin on the free wall of the RVOT, and the positive 1 means it's more posterior. AVL positive means that the PVC should be in the lower part, but this is one of the examples and exceptions of PVCs originating from the pulmonary artery. So the second ECG belongs to a 36-year-old woman with a family history of sudden cardiac death. His father died suddenly at the age of 37. She experienced herself an aborted sudden cardiac death at the age of 34, received ICD implantations, and as I stated earlier, all the tests including echocardiography, coronary angio, cardiac MRI, genetic analysis, and Ajmalin test were all normal. At the first glance, the ECG may look normal, but looking closer at the inferior leads, we can easily see the early repolarization pattern. So the early repolarization pattern combined with history of aborted sudden cardiac death makes the diagnosis of early repolarization syndrome in this young woman. In this ECG, we see the typical reason for ventricular fibrillation in early repolarization syndrome, which is early coupled, very short coupled PVCs. In this case, PVCs with left bundle branch block pattern and very late transition, which shows a right ventricular origin of these PVCs. Once again, thank you for joining me in this short video presentation regarding this week's ECG exercises. I hope you enjoyed it, and I'm looking forward to have you here in my future video presentations and ECG exercises. Thank you.